Good afternoon, everybody, and welcome to this RI3E Operational Research Project Dissemination webinar. So the title of the webinar is Sustaining Malaria Community Health Worker Networks by Expansion of Their Roles Beyond Malaria and Integration into the Primary Health System. So we're going to present the results of Operational Research Project funded by the Global Fund through the RI3E. And we have 4 speakers today. There's myself, who's head of epidemiology from Mahidol Oxford Research Unit and co-chair of the APMEN Surveillance and Response Working Group. We also have Masaya Siramutayanant, who's coordinator of APMEN SRWG based at MORU. Panarasri Komputsa, who's an epidemiologist in our epidemiology department at MORU. And Monapat Jongdi Paisal, who's a social scientist in our epidemiology department. So this project came from a declared need to conduct operational research on this particular topic from the survey done in preparation for the RI3 grant, and it was one of the projects commissioned through that grant. So it's a set of different research projects around this key theme. So we've applied multiple different methods. And one of the outcomes and the follow-on activities is we've been asked to contribute to developing new guidance on measuring the performance of malaria community health workers. So the Community Health Committee at Rollback Malaria that I co-chair, it's the key task for that committee. We are seeking interested parties to contribute to development of that guidance. So you can email myself at this address, or also we'll have a pop-up where you can register your interest if you'd like to be involved in the development of that guidance. So this is a global guidance, and it's an identified gap. And it's aimed at all national malaria programs and ministries of health. So it's quite cross-cutting. So audio and video of attendees in this meeting will be disabled. There are also people attending in person in the room. People online can submit comments in the chat box, but if you have a question, please enter it in the Q&A box. Just join that. Yep, housekeeping and agenda. We're having comments that the sound is not coming through. Can you hear us at the moment? Okay, did you hear from the first slide, or shall we go back? Yes, okay, let's continue. So if you have a question, please enter it in the Q&A box. So if you're not familiar with Zoom, there's an icon at the bottom of the screen marked Q&A, which is different from the chat box. So we're going to cover an overview of this RI3E operational research project and the various components, including a landscaping exercise, which is Asia Pacific wide, comprising a systematic review, scoping survey, interviews of implementing organizations, many of which are represented amongst the audience today. There'll be a Q&A and a quick poll around this guideline development. And we will talk about country-specific studies which are part of this wider project focused on Cambodia, Thailand, and Vietnam. Cover some of the limitations, summary of the findings, and then there is a set of recommendations that came out of it for the RI, and talk about what happened for dissemination, and then next steps with time for questions and discussion at the end. So the interventional policy under study was about integration and sustainability of malaria programs in health systems, specifically expansion of village malaria worker roles to sustain them into the future. So that's providing health services beyond malaria. We aim to identify and characterize expanded village malaria worker programs in the Asia Pacific and identify factors determining successful implementation. In Cambodia, Thailand, and Vietnam, we went into more depth to determine the acceptability of different expanded BMW services and integration into the wider health system. And then with a goal to produce implementation packages for each of the national programs, outlining steps and considerations for expanding and or integrating these services. So as I mentioned, it was funded through the Regional Artemisinin Resistance Initiative grant. So that's the number three, through the Global Fund. And it was implemented from January 2021 through to the end of this month, March 2023. And the main goal is to have outputs ready in time to inform the RIVE4 funding request. There were two main components: Work Package A, which is the focus of today's dissemination webinar, and then Work Package B, which is continuing in Cambodia. Work Package B is piloting in the field, particularly new expanded roles for village malaria workers. So we will cover the systematic review, scoping survey, and implementer interviews as the landscaping across Asia Pacific. And then we'll talk specifically about Cambodia, Thailand, and Vietnam, where we did surveys in the community with some stakeholder analysis and interviews, and then mention about the next steps, including the implementation package development. There was a range of partners and collaborators involved in this project, as you can see listed here on the screen. I think some people are on the call from some of those partners, and we'll mention them as we go along for each of the components. I'd just like to highlight AppMen helping support this webinar and the technical running of the webinar. Okay, so I'll hand over.
Hi, thanks, Richard. I hope everyone can hear me well. It's Messiah. I'll just talk about some of the methods and the findings from the landscaping component systematic review and scoping survey before passing down to the next speaker. So before we actually talk about the study itself, I would like to keep some definitions in your mind as we go through, because we will be mentioning them on and off throughout the presentation. First is the term community health workers, which we use throughout the presentation. It's the target of our study as well. For this study in particular, we adopted a broader term than the one that's used by the WHO, and the one that the definitions that's written here on the slide is the one for the WHO, which is they are considered healthcare providers who live in the community that they serve, but they receive a lower level of formal education and training than professional healthcare workers such as nurses or doctors. So in addition to this more narrow term, we use the community health worker term to cover including facility-based workers. And that's because we would like to expand the coverage as much as possible and be as inclusive as possible for different programs across the Asia Pacific. Though please note, any facility-based community health workers we mentioned in this study are also workers who perform outreach activities within local communities. So they do go out into villages and perform either malaria and non-malaria services as well. Additionally, we also know the term VMWs, which a lot of you might be familiar with in call today, village malaria workers. We will be referring to any CHWs or community health worker in the region as VMWs. As we all know, VMWs are community members who are recruited and trained to perform malaria-related activities or services. These could be diagnosis or treatment of malaria. And the reason we chose VMW as the only term is because across the region and the sub-region, we have different nomenclature for this group of workers. For example, in Thailand, we have the malaria post workers, or the village health volunteers, who might have been trained to do malaria services. We also have mobile malaria workers in Myanmar, integrated community malaria volunteers in Myanmar, sorry, mobile malaria workers in Cambodia, and malaria post workers in Vietnam. So a variety of names we will refer quite briefly and shortly as VMWs throughout this presentation. And yeah, it's fine. And the other terms I would like everyone to keep in mind as we go through the presentations is some of these that are provided to us or given to us by University of California, San Francisco. First, integration, which is defined as the expansion and or alignment of VMW or CHW programs to cover more than one health service or disease of concern. We also talk about different ways of which services could be delivered throughout the presentation, including horizontal delivery and vertical. Horizontal delivery being the delivery of services through publicly financed health systems. This is something we're maybe familiar with as comprehensive primary health care. And the vertical delivery, which we are familiar with as being the malaria programs across our region, is the delivery of health services that are selectively targeting specific interventions and may not be fully integrated in the local health system. Right, so for the aims of both the systematic review and the scoping survey, we would like to identify what roles beyond malaria are being performed by community health workers across the region, as well as characterize their programs. More specifically, the systematic review would like to look for and identify roles beyond malaria services, collect evidence for impact on various health outcomes, including malaria, and including incidence and death rates for malaria outcomes, and also characterize strategies that were used to ensure sustainability. In addition to these three aims, the scoping survey also is intended to collect any updated information about programs that might have been missed in the systematic review and fill in any gaps that we found in prior. And we would also use the scoping survey findings to help select and identify programs for further investigation during the implementer interviews as well. So the systematic reviews protocol was registered on Prospero when we first conducted this, before we conducted the search in 2021. We used the following search terms on the right-hand side in the blue box: malaria terms, the interventions, their outcomes, as well as delimiting to the countries or the sub-region in the Asia Pacific. And we adapted and worked with the Medallion Library in Oxford to develop a search strategy that would be replicable across different databases. And we searched the following databases on the left, you see here: Medline, Embase, Global Health, Cochrane, WHO Global Index, Medicus, and PubMed. We also adapted the search strategy in various formats and searched Google Scholar as well in July of 2021. In addition to these database searches, we also conducted gray literature search on APMEN partner websites and other organization websites, any organization we found from the systematic review searches as well. From the systematic review searches, we go on to their websites to look for material that we can, or reports that we can extract from. And we also conducted citation searching, so just reviewed citations for relevant publications for any papers that we choose to extract. Yeah, so for the systematic review, we have the following three required inclusion criteria. These reports or papers need to identify a community health worker or a related group. It needs to focus on malaria programs in Asia Pacific countries, and it needs to identify an expanded role. So it needs to talk about a role that's beyond malaria services that they provide. It also has to follow one of the following inclusion criteria. So not all of them, but one of the following needs to qualify in order for us to extract. The first one being providing analysis on an outcome or impact of the community health worker program on malaria or other health outcomes, provide information on sustainability of these programs, or our qualitative studies, case studies, process evaluations, and or cost effectiveness studies that can identify barriers to or facilitators of effective implementation. We also have a few exclusion criteria here. We only include English papers, so nothing that's not written in English language. We would only cite papers of which the full text can be retrieved, and any paper that reports activities outside of the Asia Pacific, we will exclude. For systematic reviews, if we find them in our search, we would citation search for relevant articles rather than extracting the systematic review itself. Right, so on the right here, you see the Prisma flowchart for our search that was conducted on both the databases and outside the databases. For the assessment of the eligibility, we had 2 review teams comprising of 4 reviewers, 2 per team, and we had a 3rd reviewer who would consult on any disagreements between the team members themselves. A total of 55 articles met the inclusion criteria 1 and 3, and you can see below the following how many papers met the other inclusion criteria. We also conducted quality assessments for any peer-reviewed articles, 39 altogether. We used the Mixed Method Appraisal Tool, or MMAT. For any gray literature, including program reports and program briefs, we used ACCADS, or Authority, Accuracy, Coverage, Objective, Date, Significance Checklist. We do not exclude any articles based on the quality that we assess, and that's just because we want to include as many programs as many reports about programs across the region as possible, just to inform our study. So for the scoping survey, we developed a 30-question questionnaire online, and these fall under 3 broad topics. 1, general information about the respondent and the program. 2, what type of community health workers they have in the program and the malaria and non-malaria services they provide. And 3, implementation characteristics, and that could be how they provide training, supervision, how they're financed, who they collaborate with, any monitoring and evaluation activities they perform, and as well as impact from COVID-19 pandemic that they would like to report. So the survey was developed in the English language and includes both multiple choice and free text responses. The questions were designed based on the findings from the systematic review. So the structure, especially the characters of the program, were found from the systematic review and integrated into the survey. But we also pilot tested the survey with a focus group of 5 potential respondents in the field, as well as among our collaborators at AFMIN and UCSF. The survey collected anonymized responses using JISC online survey platform. And we asked the respondents to respond based on how the program was operating at the time that they did the survey, or if the program was no longer active, we asked them to respond based on how it operated right prior to discontinuation. As mentioned, this was a self-administered online survey we sent out through our AFMIN portal email. So most of the survey was sent out to national malaria programs in the Asia Pacific countries and implementers among AFMIN partners and other organizations, as I mentioned, that we identified through the systematic review. The target respondents were staff that were directly involved in managing or implementing community health worker programs. And that's so that because a lot of the questions were very, very detailed, and we would need that level of understanding of the program to be responding to these questions. In terms of what responses we got, most of the responses we received were from government or NMCP, as well as international organizations. But we also got responses from NGOs, academic research institutions, or even the private sector who have implemented community health worker programs. In terms of respondent types, the majority or half are director or manager level respondents. We also have equal parts technical advisors, specialists, and program project officers. So from the systematic review, we found from the 55 reports from the systematic review, we find 29 programs in 13 countries. From the survey, we received 35 eligible responses that identified 28 programs in 14 countries. So we deduplicated between these 2 sources, I guess, and then we found there were 47 programs across 18 countries in the Asia Pacific, with community health workers performing a wide variety of roles, including non-malaria roles. So on the left, you'll see a label listing the roles that are beyond malaria that these community health workers perform. Before I get into the details, just note the size of the pie that you see across the map only determines how many programs we found in each country. So if you see Solomon Island, we found 1 program, it'll be a smaller circle. For Myanmar, where we found the most programs, we'll see that it's the largest pie. In terms of the division of what roles is being performed in the country, it is by no means a ratio. Just the colors indicate whether that role was reported in that country or not, being performed by any community health worker in that country. So the point is just to show you the vast range of non-malaria roles that are being performed across the region. And in some countries, community health workers are found to perform a variety of roles at the same time. In some countries, just 1 extra role from a malaria role, as you see in Solomon Island. So beyond the discussion of roles, in the systematic review, we actually found that there was a lack of published evidence of community health worker impact on malaria or on other disease outcomes. We also found a lot of characteristics that were reported to be crucial for sustainability. For one, adequate policy and funding from the national level was found to be very important. Tailored incentive packages for community health workers was important for motivating them. Lastly, designing programs and services that are responsive to target communities were found to be important for sustaining uptake of services within the local communities. Engaging with local health systems, such as making sure that the connection or the referral system is functional, has also contributed to maintaining uptake in the community. From the scoping survey side, we actually found that most programs do conduct monitoring, evaluation, and impact assessments. These were frequently done internally and or for funder reporting. As such, a lot of these might not have been reported and not found in the systematic review. We also find that the self-reported views of respondents, the number 1 factor that contributes to sustainability is ongoing funding. I think this is something that we are quite aware of. But what was interesting from our self-reported views was that different participants contribute different strategies to success. For one, a lot of program respondents said that being integrated or having a horizontal delivery of services has contributed to sustainability. But a number of respondents also said being part of a vertical program has maintained their program functionality over time as well. And an important lesson we learned from the scoping survey is also that lessons that were found from the COVID-19 or experiences during the COVID-19 pandemic, we found that a lot of programs reported that having a group of community health workers on the ground that were well trained and well supervised were important or good human resources that could be used to help respond to public health emergencies when times of a great pandemic that we experience has stopped a lot of movement and activities on the ground. That concludes my section, and we'll have Ms. Panarasi present.
Good afternoon, everyone. So I'm Panarasi Konpusa. I'm going to talk about the implementer interviews conducted by our colleague in University of California, San Francisco, Dr. Laura Bubak and her team. So the aims of the implementer interviews include to develop consideration for leveraging existing careers of community health workers for expanded services within the context of malaria elimination in the Asia Pacific, to document community health worker programs that include health services in addition to malaria, to understand the process and experience of community health worker role expansion, including how expanded services are implemented and managed, the training, monitoring, and supervision of expanded or integrated services, the financial cost of implementation and funding sources, and the policy factors affecting the rollout and sustainability. Sustainability of integrated expanded health worker models. So the study used qualitative method to understand implementation experiences. Semi-structured interviews with managers from implementing organizations were used in 8 countries, 13 programs, and 21 respondents. Only currently implementing community health worker program covering multiple diseases and services are included in this study. The notes from the interview are transported into an analysis matrix with key themes identified and analyzed. On the map on the right-hand side, countries that interviews were taken place are Afghanistan, Nepal, Bhutan, Myanmar, Cambodia, Malaysia, Bangladesh, and India. So 3 programs in Myanmar were interviewed, 2 in Cambodia, Malaysia, and India were interviewed, and the rest, only 1 program were interviewed. One size does not fit all. This is the key finding from this interview. The example from the Asia Pacific region show integration at various levels and within various program dimensions, from national policy to community level dialogues, depending on the country context. VMW role expansion can be achieved by combining 2 vertical programs such as malaria and TB, or it may be an overall horizontal approach to primary health care. Integration can take place in any of multiple program domains and does not necessarily occur in all domains at once. Programs may integrate one domain while maintaining vertical program operation in other domains, or may work through a process of integrating domains over time. There are various entry points for integrating VMW into additional diseases and a larger health system, but there is no universal starting point yet. Lesson learned from the interviews for consideration for implementation and sustainability. These can be classified according to policy consideration or lower levels, which will be reported later. Challenges occur at the policy consideration occur for funding, planning of the program, the mapping of BMW, and the program acceptability. For funding, most health funding targets specific disease and does not foster integration. So it is therefore suggested for increased coordination of funding mechanism and programs. The integrated of funding will incentivize integrated program. The policymaker or program manager might consider public-private partnership funding. About planning, it is found that vertical funding streams, mechanism, and programs often have uncoordinated planning and policy processes. Champions at the national level of expanded roles is suggested to maintain commitment of uniting different health programs. For mapping of community health workers, it is unclear where community health workers exist and their roles within the countries. The rosters out of date suggest to update landscaping mapping of community health worker roles, their skills, the location at both national and subnational levels. For program acceptability, programs do not always meet community health needs or align with community health worker capacity. Suggest to increase evidence and participatory research, consulting community health workers and communities. Next, please. Challenges occur at practical steps, include training, guidelines, standards, and materials, mentorship and supervision, and data collection and data use by community health workers. For training, expanded role require additional training among limited resource setting. So it is suggested that cost sharing among different programs can develop, which will bring efficiency to training, or maybe integrating new topic into refresher training can also reduce cost. For guidelines, standard, and materials, expanded program have sometimes lacked these guidelines from central level to guide BMW new role. So therefore, there should be clear guidelines, training, implementation materials for expanded roles, including specific educational requirement or term of reference for community health worker. For mentorship and supervision, community health workers taking on new roles sometimes struggle and require mentorship and supervision. However, supervision is resource intensive. Recommend for mentorship group through phone or telegram, or schedule supervision visit, targeting those with challenges or low score might be a way out. Challenges about data collection and data use by community health worker. Community health worker collection and use of data is suboptimal overall, and this can threaten success of expanded roles. There should be clear strategy for integrating data into surveillance system, data use, and focus on program design, training, and supervision. Some consideration about enabling factors for implementation and sustainability. Challenges can be about flexibility, about referral system, about supply chain, and about the community role. About for the lack of flexibility, there are often large variations of context within a country that require different community health worker approaches to meet the local needs. It is suggested to have sharing committees at provincial or local level to enable flexibility in decentralized planning process, and especially COVID-related role expansion. There is overall weak referral system. If expanding rules to include diagnosing more complicated conditions, that the dependable health facility must be in place. Also suggested to evaluate and strengthen referral system alongside consideration of expanded roles. Supply chain challenges. Many competing supply chains exist for different health programs, and communities stock out frequent. The program should minimize the number of vertical supply chain and consolidate community distribution process. As malaria burden decline, some community health workers fear that social role, value, or acceptance will decline. So it is suggested to leverage existing village health committees to expand scope and ensure uptake of new services, or consider community priorities. Next, please. Again, it is concluded that one size does not fit all. The program can start from policy and financing, development, or about planning and research step, or during the selection, training, and motivation of community health worker, or at the management, supervision, and monitoring of the program, or at the health system structure, or at the community engagement, or in the hard to reach communities. Let's look at some examples from the interviews. In Bangladesh, they developed community health worker policy at the policy level. In India, they developed the public-private partnerships specific to one program called the demonstration. Sorry, MEDP program. Okay, another example at the planning and research. Cambodia, they use community health worker mapping in the planning. In Myanmar, they use participatory action research on community needs to inform the planning. In Malaysia, they use non-financial incentive to motivate community health workers. In Bhutan, they have a scheme called Cadre of Community Health Worker and incentive. For the management and supervision and monitoring of the program, in Myanmar, there is supervision and refresher training in ICCM, integrated community care, integrated community case management, sorry. Yeah. In India, there is advanced tour plan for MEDP for the program management. At the health system structure, Nepal used local steering committee. In India, in Chhattisgarh state, there is a Mitanin structure, health structure, Mitanin group in the health system structure. At the community engagement, Bhutan used community action group to support their work. In Cambodia, there are community dialogue for engagement. And in Afghanistan, there is a family health house for providing service to community in hard to reach community. So we can see that the start of integration can take place at different location in the public health system, from policy financing to planning to selection of community health worker to health system to community engagement. So it is not to conclude that which one lead to the sustainability, but sustaining program show different integration at different point as shown in this diagram. So thank you for your attention.
Okay, so we'll take a brief pause to take any questions or discussion points. If you have any, please type them in the Q&A box at the bottom before we move on to the country-specific findings. And while you're thinking of questions, we're also going to run the poll. So as I mentioned at the beginning, so the Rollback Malaria Community Health Committee that I co-chair, we've been tasked with developing new global guidance and measuring the performance of malaria community health workers. We're seeking interested parties to help develop those guidelines, to be involved in the development group. There's a poll that should pop up on your screen. You can register interest there if you wish. Otherwise, you can also email me for more information or further discussion. So please feel free to complete that poll and also to type in questions. So it must have been very clear or very unclear because there's no questions so far. That's good. Yeah, we're going to leave the poll open for a couple of minutes. We can actually see results on our screen, so you can't, unfortunately. And there'll also be time for questions at the end after we finish the country-specific part. So how many responses do we have? 17 so far. Yeah, so just another minute. Please feel free to say no, it's okay. So the next steps for this development will be brainstorming in our own group tomorrow, and then we'll be convening an online meeting to discuss an outline of this guidance. There's also other partner organizations that we're discussing with who've already registered their interest. And there'll be a series of online meetings, and then we will be developing this as a community online, as a living document. Great, so thank you very much everyone who's just filled that in. We have 26 responses, and we'll take those and we'll get back in touch with you if you've indicated an interest. Otherwise, we'll move on to the next part.
Thank you, Richard. So for the second half of this presentation, we'll be focusing on the methods and the key results of the community survey and stakeholder analysis that were conducted in Cambodia, Thailand, and Vietnam. My name is Monapat. I'm presenting on these findings on behalf of our bigger team who help us conducting the activities, the research activities within all three countries. For these two components, the community survey and the stakeholder analysis, the aim is that we want to understand the views of the policymakers and the beneficiaries of the community-based programs, including village malaria workers program that are existing within each countries. Specifically for the stakeholder analysis, we want to understand what is the policy background of those programs in each country. We also want to understand the views of the stakeholders about what they think of the past design and implementation of the programs within the country. And we also want to know what they think are the prospects of expanding the roles of village malaria workers in each country. At the same time, we also want to understand from the bottom-up perspectives of the communities who are affected by the programs, what are the needs and preferences for expanding the roles within their own community? How do they currently seek care? And we also talk to the village malaria workers themselves about the views of expanding their roles and what support would they need if their role were to be expanded. And the approach here is that we want to understand both from top down, from policymakers, and bottom up perspectives of the communities in assessing the acceptability and what is the feasibility of expansion of roles of village malaria workers. And at the same time, these data and these studies will be analyzed comparatively to identify whether there's any differences or similarities among countries in the region. So in terms of the methods for the stakeholder analysis, we employed perspective policy analysis, which comprises rapid review of policy documents and the studies within each country, followed by a mapping of stakeholders and interviews of key informants using purposive sampling to recruited key informants. The interview participants include both domestic stakeholders and international stakeholders. These includes health sectors managers within the central, national level and provincial level, researchers who have expertise in community-based care, and representatives of funding agencies and international organizations within the region. In terms of data collection, we interviewed the key informants using semi-structured interview guide that is tailored to the role of each informant and their expertise. And thus, some of the questions and guides were refined with themes that may emerge during the interviews. The interviews are also recorded and transcribed and were analyzed thematically using selective and open coding and through inductive iterative approach, which means that we go back and analyze data. We go back and do the next interview to enrich the information that we may get from the following interviews until the data is saturated. And in the when we're doing these analysis, we also produce a matrix table that kind of map out stakeholders within each country and within each category. And here on this slide, you can see that we classify stakeholders within three main groups, at least three main groups. One is within the malaria program, which refers to policymakers and program managers that are within the national malaria programs and may also be key responsible to implement malaria interventions and may also directly manages the village malaria workers within the country. And secondly, we identified stakeholders within the general health system, which refers to the departments within the Ministry of Health or Ministry of Public Health in each country, which may also implement other health programs. And in addition to these two types of health programs and health systems, we also classify them by whether they're at the national level, subnational level, or within the community level. We also identify key stakeholders within the international organizations who may play a role in providing technical and financial assistance to malaria programs existing in the countries, as well as representatives from the civil society organizations who may also implement their own malaria programs and may or may not also manage their own volunteers within the CSOs. And the table below shows the number of the key informants we interview within each country. And for the community survey, we employed a mixed method approach comprising qualitative and quantitative approaches to identify the preference and needs and the perspectives of the communities that we surveyed. We first consulted with consulted with local health authorities, the village leaders, and village malaria workers about how to best approach committee members to recruit them to join the questionnaires. And the committee members who consent to join the questionnaire-based survey will be asked to spend about 20 minutes with our research team to respond to the questionnaires. And this is a staff administered survey whereby staff would be asking listed questions and recorded the responses of the committee members onto either an electronic device using Kobo toolbox or on a paper-based form, which will be later entered onto the toolbox. To get a more enriched in-depth information from the committee members, a smaller group of them will also be invited to join a longer interview where we conducted interviews of about 50 to 60 minutes long with committee members. And purposive sampling is used to identify some of the targeted interviewees who may have already had malaria in the past or have visited village malaria workers in their community for their services. At the same time, we also employ some snowball sampling to identify some of the community members who may not have had malaria or may not have frequent village malaria workers for their services prior. And this is to enrich the information about those who have had malaria and how they use the service provided by the workers and those who may not have used the service prior. At the same time, we also conducted focus group discussions to explore some of the perspectives of the committee members in a group discussion setting. And this is important to gain some more information that we may have missed when we're doing the questionnaires or in-depth interviews. And how we conduct the focus group discussion is we recruit participants who may share the same profile of demographic, for example, group within the same age range or same gender. And we also conducted ones that are more diversified, for example, a group of 8 committee members comprising 4 male and 4 female respondents. And these mixed method approach kind of allow the team to triangulate between the information that we receive from a larger group of people based on the questionnaires and enrich them with more in-depth information that we got from the in-depth interviews and discussion setting. Sorry about the slides. The main criteria that we use to select the study sites for these community surveys are that they must be nearly elimination. And we did consultation with the national programs within each country where this is feasible within the project timeframe. So the map on the right here shows the other communities. So you can see here that we conducted the surveys with 6 communes in Kravan district in Prasat province in Cambodia. 6 districts in Sisaket and Punraj Thani provinces in Northeast Thailand, and 6 communes in Binh Thuan and Phu Yen provinces in Vietnam. Majority of these communities are remote, located close to the forest or for some very mountainous. As you can see here in Cambodia and in Thailand, they're located close to the national parks. And for Thailand, most of these communities are located along the international border between Thailand and Laos and Cambodia. The data collection for the community survey is conducted during January to April 2022, during which the country may also see a number of COVID-19 cases within these communities. And the table below shows the number of the recruited participants for each activity, either for interviews, questionnaires, focus group within each country. So here I'll go talk about the key findings that we got from the community survey. Firstly, from the interviews that we did with majority with the village malaria workers, the majority of them we found have already performed multiple roles in their communities beyond malaria. And this is because some of them may have already taken up the role of community health volunteers or workers that belongs to the primary care system within the country. The main roles are to assist local public health facilities that are close to the communities, for example, community health station in Vietnam, health center in Cambodia, or health promotion hospital in Thailand. Some of them may also be recruited to perform specific health programs, for example, maternal and child health program in Cambodia or tuberculosis program in Vietnam. And some of them may also perform roles that are beyond health, such as volunteers who work for the local government in Thailand or with the non-public health departments in the country. In all three countries, we found that a majority of malaria workers, they're also local people who are engaged in agricultural activities. And these are commonly either their main or alternative source of income. And the table on the right here shows you an example work profile of malaria post workers in Thailand, 13 malaria post workers within the communities who are trained as malaria workers with a range of 4 to 14 years of experience, and the fact that they're also performing other roles beyond malaria, for example, assisting village health volunteers, assisting village leader, a representative of the village to the local health authority or local administrative authority within their own communities. With these multiple roles that these malaria workers perform, we found that to a certain extent, the village malaria workers are well linked to the primary care units and the primary healthcare system within their own communities. And then some of their roles are assigned to provide health education, to do home visits and case referral to health facility. We also found that majority of the village malaria workers valued and benefited from the training and supervisory activities that were provided by the malaria programs. At the same time, they also reported they prefer to receive a regular compensation, for example, daily wage and transport support to perform some of these roles. From the interviews, majority of the malaria workers have expressed their willingness to expand their roles and talk about their motivations. For example, the compensation that they may receive from these performing these additional roles, whether they can contribute more to the communities that they serve or receive the respect from the community that they provided service for. And for some also talk about an opportunity for expansion of roles in terms of career advancement. For example, village health workers in Vietnam who may see this opportunity as a career advancement to pursue a more career in community health station in the future. However, with these opportunities, the village malaria workers we interviewed also reported some of the challenges that may already occurred, or for some of them, or if they were to perform expanded role, they might feel that they might be overburdened with some of the multiple roles that they need to perform. Some of them are also concerned about whether they will be underpaid from these roles if they were to perform additional roles. And some of them also reported they are concerned whether they'll underperform some of these roles with certain limitations that they may face within the community. For example, if there's limited internet connectivity in where they live and provide the services, limited devices, technological devices that they may require, or even digital literacy skills. And this is especially the case for some of the tasks that might require data reporting and documentation within the communities. From the community survey side and interviews and focus group discussion, this table summarizes some of the key health concerns and preferences for services beyond, including malaria and beyond malaria within the communities in the three countries. We can see the symptoms like colds, fever, diarrhea are often mentioned to be common concerns among the community members, as well as some of the non-communicable diseases such as diabetes, which is commonly experienced by the local people within all the three countries. And beyond illness-specific roles, we also heard some of the communities request that there should be more home-based care provided by volunteers and health workers, providing first aid or care for the elderly within their own community, and that the better referral system should be taken place to help the community members, especially within more remote areas, to reach primary care units and hospital in a timely manner. Some of the communities also talk about whether some of the service provision could be provided by volunteers in a community share space rather than at their own house. And from the interviews, we also found that community members who have malaria in the past value that malaria services are located close to their home. It's convenient for them to visit. And this is also expressed when we ask them whether they're willing to pay for additional services. And the response is that some of the community members may be willing to pay if the cost of those additional roles is proportionate to alternative source of treatment. For example, them having to pay for travel costs to the health facility or purchasing medicine at a pharmacy. We also found that some community members may be concerned with some of the tasks that may be provided by volunteers, for example, performing a blood test by a non-medical professional, and this is very much related to whether the village malaria workers is eligible to perform some of these roles. But at the same time, we also found that village malaria workers parties, some of the committee members may be concerned about visiting a public health facility for fear of disclosing some of their travel history if they were with malaria, or disclosing some of the information about substance use to public health officials. So with these inputs from the communities and from the village malaria workers, we found that it's important for village malaria workers, if they will continue to maintain their contribution to communities, that ensuring their skills with the roles that they are performing and maintain that, and also to keep the services accessible and responsive to community needs is crucial. Now we'll also look at the perceptions of the stakeholders regarding, firstly, the public health value of the village malaria workers. Majority of the stakeholders we interview in all three countries perceive that although road access to health centers and hospital has improved significantly in the past years, many communities, especially those that are malaria endemic, are still very hard to reach, especially during the rainy season. And village malaria workers is an important link between these communities and health facility during those times. Village malaria workers also perceived to be the key people who understand the culture and language of the people within these communities. And they're also local people who live in the communities for many years, and therefore can build trust and relationships with the community members and their clients. Hence, majority of the stakeholders that we interview perceive that their roles of village malaria workers could be expanded to serve better the changing public health needs in these communities, especially in communities where malaria is no longer seen as a priority, and therefore some of these specialized village malaria workers may be underutilized. This table summarizes some of the key suggestions from the stakeholders in all three countries on what expanded role village malaria workers could perform in the future. And in Cambodia, for example, stakeholders perceived that the village malaria workers could be trained to perform some surveillance and health education for other vector-borne diseases beyond malaria, provide health information and prevention for non-communicable diseases, and perform some of the roles within the maternal and child health care programs. For Thailand, they could be trained to screen symptoms for common illnesses specified in the communities, provide health information and basic care for diarrhea or some first aid assistance, and to screen for diabetes and monitor blood pressure. And in Vietnam, it was suggested that the village malaria workers could perform case notification for infectious diseases, collect and report real-time data for those cases. From the interview with the stakeholders, we also asked what are the policy considerations that are crucial for if the program were to consider expanding the role of the village malaria workers. And we grouped the consideration within 4 main themes. First, alignment. Majority of the stakeholders perceive that if there's to be any upgraded to the village malaria workers program in the country, that it should align with the national policy guidance within each country. For example, Center of Disease Control Regulation in Vietnam, non-communicable disease prevention policy in Cambodia, and community-based volunteers guideline in Thailand. They also need to be responsive to the changing public health needs in the communities to maintain the relevance to the communities. And certain tools, rapid assessment, such as participatory reverse appraisal, is suggested to be useful in these circumstances. Regarding program design, the stakeholders perceive that village malaria workers should act as a link between the health sector and the communities, rather than taking over the clinical tasks that may be already performed by healthcare workers within the communities. For example, they should be able to test and screen rather than diagnosis. And if programs were to expand the role of the village malaria workers, they should also consider carefully the capacities of the malaria workers, their training requirements, and the financial incentives that are appropriate to the group of workers. In terms of testing services, suggestions were given that maybe village malaria workers could also perform testing for other infectious diseases such as dengue or chikungunya, provide some NCD prevention measures if there is sufficient training and supervisory support for those roles. In terms of financing, stakeholders perceive that external financing is expected to reduce over time, and that domestic funding may not be sufficient to maintain the current standard of program implementation and nevertheless support the program expansion. Hence, local funding and authorities were perceived to may be able to step in and sustain some of these activities that were implementing within the communities, and which also aligns with the decentralization processes that may already be happening in the country. And last but not least, in terms of governance, some of the stakeholders perceive that donor-funded program should be integrated into the national health system, and there should be a shift toward local ownership for some of these programs. And this is considering the legal constraints that some of these malaria workers may be facing that may limit their ability to offer testing services and medicines within the communities. Just before we conclude our summary of findings, our study not without their limitations, and here we noted down some of the key limitations that may present in each component. So for the systematic review, we found the review is a retrospective investigation of ongoing and past programs. Hence, literature searches that we conducted may not capture the programs that have yet to report about their activities or yet publish about their work in English. And for the scoping survey, we did not receive responses from all the countries in the Asia Pacific region. And we also received multiple responses from countries where there may be a lot of malaria programs that are implementing or actively engaging with admin or are active subrecipient of the donors within the region. For implementer interviews, the studies provide case studies that are context-specific examples, and they are not necessarily generalizable or applicable to other countries. We employed qualitative methods that focus on a few examples, thus the programs are not exhaustive of all the programs that may exist in the region. For the stakeholder analysis and community survey within each country, we did not reach a lot of respondents outside of the public health sector or Ministry of Public Health in each country. And for the community survey, the selection of study sites may limit the generalizability of the finding to only near elimination setting. And in Vietnam, respondent selection is based more at the health facility level rather than at the household level. So the representativeness of the respondents may be limited in that sense. Just here before I pass on to Richard, just to summarize our findings that my colleagues have presented in the first half and what we have seen from the country-specific findings, we found that malaria community health workers have been shown to do multiple roles, including direct and non-direct care services if they were provided with adequate training and support. At the same time, we also found that there's limited evidence in terms of impact on health outcomes of these programs. And hence, program measurement is vital to understand these programs in low transmission setting. We also found that from the community survey that the community health needs varies in each context, and package of roles that village malaria workers could perform in the future can differ, and they can also be tailored to local health priorities. We also found that village malaria workers in these countries perform multiple roles, and some of the roles might be overlapping with some of the existing volunteers that already exist in the countries. And hence, with these considerations, we found that a way to expand or integrate the roles of village malaria workers the best approach to that or channel to make it happen might need to be contextualized to the local health system to make it more sustainable. Now I'll pass it on to Richard to talk about dissemination.
Thanks, Sai. So there was a number of steps taken to disseminate the findings from this project, in particular to the national malaria programs and also regional bodies. We produced a set of recommendations at different levels. So there were country-specific recommendations, which I won't go through now. And then we had a set of recommendations for the region, in part because of the regional Y4 grant. So this is particularly aimed at the writing teams in the countries for that grant. But there were some cross-cutting recommendations I'll just mention briefly. One is the need to landscape current community health worker roles across each country. So to know what community health workers are currently doing, both for malaria and also outside of malaria, in part because of this overlap that we identified in each country, people taking multiple jobs, often having multiple skill sets and not being clearly known about and quantified. So we recommended survey existing community health workers in malaria endemic provinces at least, to then list out their roles, activities and skills, then to map out where they're working and how many there are. to use this information to devise local integration plans in each province or district and in the country. That includes training, supervision, M&E, and identifying gaps in skills for expanding to particular roles. Identifying activities where there are efficiencies by combining efforts, for example, multiple different things during the same training, workshop or event, or supervising across different activities. There's a need to tailor activities to local health needs because the health burden and health priorities varies quite substantially across each country. So there are particular diseases that are concentrated in certain areas and are absent elsewhere. So recommendation was to conduct a community health needs survey in each of the country to identify what those needs are, and then identify from that what the mix of skills should be and what those roles should be in each of the areas. So to tailor those roles to the local needs. That ideally should be done annually because those needs change over time. So there's also a recommendation for more stakeholder engagement, but led by the national programs and then adapted to the country context, including selection of who those stakeholders should be. So that's to select the expanded malaria community health worker roles and how to integrate them. Those engagement activities could be done regularly, for example, twice a year or 4 times a year, and that should be multi-sectoral with some sort of coordination mechanism led by the national program. And also another recommendation to look at alternative sources of funding. And there are a number of examples that are identified from the landscaping and some recommended from the various interviews. So some activities, of course, are fundable from the Global Fund grants, so the malaria specific component, but also TB, HIV, and the RSSH component. So particularly where this goes outside of one specific disease and it's cross-cutting. There's also potential other sources of funding, so co-financing with primary care, so that could be domestic funding or with other vertical disease programs. There's the non-health budget, so often these health coordination is done at provincial level and it's outside of the Ministry of Health. There's a local government administration which has a separate budget which can be used towards this. And then we mentioned an example of public-private partnerships as well. So the dissemination that we've conducted so far, we've developed a set of policy briefs for each of the countries and also regionally. We collaborated with Open, which is a team in Oxford, they're experts in this sort of policy brief development. And we've produced a set of key findings and recommendations for each of the countries, and then also for the Greater Mekong region for the 5 countries. We've conducted workshops with each of the 3 project countries to go through the findings and also the preliminary recommendations to come up with the final set that were then disseminated more widely. The key findings and the recommendations were presented to the RSC Operational Research Committee, so in their meeting, and then also as a set of reports, so country specific and regional, on all the different components that we've presented. Those reports were shared with the countries and their grant writing teams, as well as the RSC, so the Regional Steering Committee for the RAI. And then in addition, the RSC held as a regional grant writing workshop, the Greater Mekong region, and our recommendations were presented in that workshop. There was a particular breakout group on this topic that I was part of. Today's webinar is presenting primarily to people that were involved in this project. So many of you would just like to thank for contributing to the interviews and also completing the surveys. So for many of you, this would be the first time to hear this, but we also plan to publish the findings as long form reports in the academic literature as open access publications. We're also awaiting feedback from the RAI4 grant writing. So that's the country grants and the regional, to see what ended up being included. And then I've also mentioned about this other next step of the requirement for global guidance on measuring the performance of malaria community health workers. So we've run the poll for that. If you missed the poll and you were interested to contribute to that development, please send me an email. There's also some discussion about whether there's a need for developing other guidance on measuring the impact, because as you've heard from the presentations, there's very little evidence of impact of malaria community health workers. And that would be very helpful for justifying going forwards. So we have time for more questions and discussion. If you'd like to put questions into the chat, we'll respond. We can also just use this chance to thank everyone that's been involved. So it's a very large team and lots of different organizations. We put the logos on the bottom right, and there's a load of names. Apologies if we've forgotten anybody. But this was a large regional effort over 2 years with strong support from APMEN, but particular components led by the ECSF, support from Marco Liberani, who's in the room from London School, Chris Powell from University of Amsterdam, I think is also on the call at the moment. The work package B activities in Cambodia are being run by AHEAD, and there'll be separate dissemination events for those. That's not quite complete. And then just to thank each of the 3 national malaria programs in Cambodia, Thailand and Vietnam